Hi. Hi everyone, my name's Ari, and today we're going to be having a chat about cranial nerves and special senses. Before we get started, could I just double check that you guys can hear me? If you can pop it on the chat, that would be great. And can you see my screen? Can't tell if the... Oh, can you guys? Yeah, okay, fantastic. Then we're gonna get cracking because this will be a kind of longer presentation, but hopefully it should all make a bit more sense after today. So, cranial nerves and special senses. Before we get started with breaking everything down, what are cranial nerves in the first place? So there are 12 paired nerves arising directly from the brain, and we will understand exactly what areas of the brain that they come from, and we need to know what they do and what course they have. So we're going to break this down into functions and anatomical course. For functions, we want to understand how can we test their function with clinical tests and their pathology. So what can go wrong? And anatomical course, what we need to focus on is origin, termination, and the cranial foramina that they go through. So the key thing here about where they originate is the rule of fours. We have 4 above the pons, 4 in the pons, and 4 below the pons, and literally just number them. So the first 4 coming from above the pons, with the olfactory and the optic coming from the anterior of the brain, the next 2 coming from the midbrain, next 4 coming from pons, and the rest coming from the medulla. And I think in your exams, they should translate each cranial nerve to the numbers, but do get comfortable with knowing which number correlates with which name. Okay, and then we will move on to have a chat about what cranial foramina that they go through. So first of all, the olfactory goes through the cribriform plate. The way I like to remember it is that the olfactory nerve is the funky nerve that has lots of spindles, which kind of correlates with the way that the cribriform plate is formed, having the many dotted lines and kind of the longer aspect to it for the olfactory nerve to go through. Then the optic canal has the optic nerve, makes sense, matches well together. And then we have the superior orbital fissure. We need to know that this is in the sphenoid together with the optic canal, and this is where a lot of other nerves that are related to the eye pass through. So while in the optic canal, the actual optic nerve goes through it, the nerves innervating the muscles of the eye pass through the superior orbital fissure. So those are the oculomotor, trochlear, ophthalmic, and abducens. Then moving on to the foramen rotundum and ovale. They're both in the sphenoid. Those will have the maxillary and the mandibular nerve, respectively. So thinking about it anatomically, the maxillary nerve will pass above as it's in the maxilla, so it will be in the foramen rotundum, which is above the foramen ovale, which will have the mandibular nerve. These are all branches of cranial nerve 5, this with having first the ophthalmic as the first branch, then the maxillary is the second, and the mandibular is the third. Perfect. And then we have the internal acoustic meatus that's in the temporal bone. And because of the word acoustic, we are thinking that nerves relating with hearing will go through there. So we have the vestibulocochlear nerve, and the facial nerve will also pass through. Then in the jugular foramen, we have our big batch of 3 nerves, which are super important: the vagus nerve, the glossopharyngeal nerve, and the accessory nerve. Those 3, I think of them as always kind of going together. And finally, the hypoglossal nerve passes through the hypoglossal canal. That's the easiest one to remember. The way I try and memorize these is just kind of bunching them up by their function. I think the SOF makes the most sense in terms of anything that innervates the kind of function and feeling around the eye area. Moving on to parasympathetic ganglia. So parasympathetic ganglia are the synapse of the preganglionic cells with postganglionic cells, which then will travel to innervate a muscle or gland, those being the effectors. Essentially, they're just swellings in the nerve where the nerve cells are found. And we need to know some key ganglia. So first of all, the ciliary ganglion, which is supplied by the oculomotor nerve. And its function is to provide motor supply to the sphincter, pupillae, and the ciliary muscles, which again makes sense, has to do with the eye, so the oculomotor nerve. Then the pterygopalatine ganglion and the submandibular ganglion go together. They're both innervated by the facial nerve. And they respectively supply various glands. The way I remember them is the pterygopalatine has to do with the palate. The palate is close to your nose and kind of the top face of your area, so that will supply the lacrimal and nasal glands, while the submandibular ganglion will supply the submandibular gland as well as the sublingual one. And finally, the otic ganglion is innervated by the glossopharyngeal nerve, which provides function to the parotid gland. Good. So now we're going to go through each cranial nerve and go through their functions as well as their course. So cranial nerve 1 is the olfactory nerve. And this is what we were talking about earlier, where we can see the olfactory bulb is placed onto the cribriform plate and we have this kind of hair-like structure. So its function is that of smell, and we can test this clinically by looking at changes in smell, and we can perform a smell test. And the main causes of issue with smell can be head trauma. A key thing to remember with smell is that it is capable, the olfactory nerve is capable of some regeneration. Then its anatomical course is that it synapses directly onto the olfactory bulb. So it originates from the olfactory epithelium in the nasal cavity, will terminate on the olfactory bulb and passes through the cribriform plate, which is in the ethmoid bone. So let's have a chat about the actual anatomy of these nerves. So the olfactory receptor neurons, ORNs, are bipolar cells who have unmyelinated axons which travel through the cribriform plate in the ethmoid bone. And these will synapse onto mitral cells. They're very delicate cells, as we said. Think of them, they're unmyelinated axons, so they can be easily damaged with any head trauma. They're grouped into different functional groups called glomeruli, and these are all organized based on different odorants. Odorants are the molecules that you sense. So you can see here the organization of the bipolar cells into glomeruli. The axons of the mitral cells will synapse directly on the olfactory cortex, forming the olfactory tract. The olfactory cortex is found in the uncus, and it has connections with the orbitofrontal cortex, amygdala, and thalamus. This is why your sense of smell has such a profound effect on your memory and can really bring back memories. And these are constantly replaced and regenerated every 1 to 2 months. Then, in terms of physiology, we need to know that the olfactory receptor neurons have a type of GPCR, which are G protein coupled receptors, to which odorants bind. Each GPCR can bind several odorants, and the different patterns of the olfactory receptor neurons activation will encode a different type of sense of smell. So the GPCR are GS coupled, which means that when they are activated, this will increase cyclic AMP generation, which will increase membrane permeability to both sodium and calcium, leading to the generation of action potentials. So key things, they're GPCRs, and these are GS coupled, which means that you will increase cyclic AMP when they're activated. In terms of clinical testing, we can perform a smell test, and when things go wrong in pathology, this is called anosmia, when you can lose your sense of smell. The main causes are head trauma, but we also saw with COVID-19 that people lost their sense of smell, and this can also happen in Parkinson's. Let's move on to cranial nerve 2, which is the optic nerve. It has a special function of vision, and we can test this clinically with the visual acuity chart. You've probably seen this when you went to the opticians. It's called the Snellen chart, and we can have various pathologies, including papilledema, glaucoma, and pituitary tumors. So we need to know quite a bit about its anatomical course. It's quite easy to test you on different visual defects and how those relate to anatomy. So the key thing that we need to know is that we have the decussation of your nasal fibers to create contralateral optic tracts which travel to the thalamus. So in terms of origin, the optic nerve originates in the retina. It terminates on the lateral geniculate nucleus of the thalamus, LGN, and its cranial foramina is the optic canal. So in terms of the actual anatomy of this, we need to know that at the back of your retina, we have three cellular layers, those being the photoreceptors, then bipolar cells, and ganglion cells. So the photoreceptors synapse with the bipolar cells, which then synapse on to the retinal ganglion cells. Photoreceptors being all the way at the back. And we have two different types of photoreceptors, rods and cones. Then in terms of phototransduction, so the physiological aspect, we need to remember the key function of rhodopsin. So photons are absorbed by rhodopsin, converting it from its cis form to its trans form. This will then activate the GPCR called transducin, which will reduce cyclic GMP, decreasing channel opening and hyperpolarizing the cell. This reduces the release of glutamate onto bipolar cells. This can also be called as the dark current, which means that when the eye is in the dark, not sensing any light, you have current passing through. But when you are sensing light, this will decrease the current that passes through. Bipolar cells themselves can be on or off types, meaning that when they are stimulated, they can either turn other cells on or off. And below the retina is pigmented epithelium, which absorbs light importantly in order to prevent reflection. We need to know the differences between rods and cones. Essentially, the main thing is that rods are more sensitive to light, and you have a lot more of them, and they are used for peripheral vision. So rods do not. Oh, sorry. Rods have a high sensitivity, can signal each photon, which gives you night vision. So when you turn off the light, you take a while to adjust, but then you're mostly using your rods because they're very sensitive to light. Another important thing is that many rods converge onto a singular bipolar neuron, and that means that they have a low level of acuity because of this high level of convergence. And as we said, in terms of distribution, they're highest in the periphery, with the pigment that we use being rhodopsin. Cones, on the other hand, are have lower sensitivity, so they're used mostly in daytime, and they have a low level of convergence. They have one-to-one connections to bipolar neurons, meaning that they have high acuity. We have a lot less of them, and they're placed in the fovea, giving us more central vision. Then what we need to know is these clinical tests. So on the right-hand side here, we have the Snellen chart, which provides us with visual acuity test. As you're reading down and you cover one eye, you can see how good your vision gets. This should be a image that you should all be familiar with soon to prep for exams, and we see that the defects in the visual field as you're cutting different areas of the optic tracts. The key thing here that we're testing is the decussation of your tracts. So as we mentioned before, the nasal fibers of your optic tracts over here decussate here, and if you cut before the decussation, that means you fully lose the visual field of one eye. If you're cutting at the decussation, that means you're losing the outer areas of your visual field on both eyes. Remember that if you're looking at the nasal fiber, that will lead you to the periphery of each end, and you just follow through from there. Now we're going to move on to the oculomotor system. So we need to know about cranial nerves 3, 4, and 6. So those being the oculomotor nerve, trochlear nerve, and abducens nerve, respectively. These all contribute to the movement of the extraocular muscles. So the oculomotor nerve is also responsible for the pupillary and accommodation reflexes. And the vestibular ocular reflex is when the oculomotor system works together with the vestibular system to keep your gaze fixed as you move your head. So the key things here, the way I like to think about it is you want to memorize the trochlear nerve and the abducens nerve, and then remember that the oculomotor nerve does everything else. So the trochlear nerve is responsible for the superior oblique muscle, which you can see over here, and that will lead to your eye moving in and down, while the abducens nerve is responsible for the lateral rectus muscle, therefore abducting the eye. The oculomotor nerve is responsible for all other muscles, as well as the superior levator palpebrae. So, cranial nerve 3 is the oculomotor nerve. As we mentioned before, it's responsible for the motor function of the levator palpebrae superioris, superior, medial, and inferior recti, as well as the inferior oblique. It also has the parasympathetic function of the ciliary ganglion, pupillary constriction, and ciliary muscle constriction. So we have a couple clinical tests to measure its function, that being of inspection, seeing if your eye is moving down and out. That means that you have an issue with your oculomotor nerve. Ptosis, diplopia, it would mean a issue with the oculomotor nerve. Ptosis is the inability to fully open up your superior eyelid. So we have an issue with the levator palpebrae. Diplopia is double vision, and then also failure of the accommodation and light reflex. Its anatomical course, it starts in the ocular motor nucleus in the midbrain, or the Edinger-Westphal nucleus, which is also in the midbrain. It terminates on the muscles in and around the eye, and it passes through the SOF. Cranial nerve 4 is the trochlear nerve. This is a lot simpler than the oculomotor one. It just innervates the superior oblique. So when we're inspecting it clinically, we will see a slightly upwards deviated eye if there's an issue with it. It decussates before leaving the brainstem. So it starts on the trochlear nucleus, which is in the midbrain, terminates on the superior oblique muscle, and passes through the SOF. Finally, cranial nerve 6 is the abducens nerve. It innervates the lateral rectus, and so if something is wrong with it, we will see a slightly upward deviation of the eye. This is because of the strength of the superior oblique. We'll just pull it up. And it starts at the abducens nucleus in the pons and terminates on the lateral rectus muscle, and it passes through the SOF as well. So we can see how all the oculomotor nerves pass through the SOF. So we need to chat about the medial longitudinal fasciculus, which is simply we need to know that it's the tract that connects the oculomotor, trochlear, and abducens nuclei, and this is in order to facilitate the coordination of your eye movements. So the retinal ganglion cells will connect to the pretectal nucleus in the midbrain, and that will connect to the Edinger-Westphal nucleus bilaterally, allowing for both pupils to constrict to the light in one eye. So this is called the accommodation reflex, and it's a negative feedback loop, preventing sudden changes of the light of an environment from damaging the retina. So we need to know that this is from parasympathetic nerves of the oculomotor nerve, synapsing onto the ciliary ganglion, innervating the sphincter of the iris, leading to pupil constriction. So if you have a non-reactive pupil when you flash light in someone's eye, that indicates damage to the optic nerve or the midbrain or oculomotor nerve. Remember that the tract is moving together. So in terms of clinical testing, these are some classic questions, and they're easy to recognize once you've learned the clinical presentations. So if you have an cranial nerve 3 palsy, will lead to a down and out eye. Cranial 4 palsy is up and in, while cranial 6 is looking to the affected side. And if you have a issue with your accommodation reflex, then that would be that could be a cranial nerve 3 palsy, while if you have an issue with your light reflex, that could be also a cranial nerve 3 palsy. So we skipped cranial nerve 5 and we're getting back to it now. That is the trigeminal nerve. So we will split its function into its sensory and motor. So its sensory is split amongst its 3 branches, 1, 2, 3, and it's responsible for touch, proprioception, and temperature. And its motor function is provided by its 3rd branch, and it innervates the muscles of mastication, tensor tympani, tensor veli palatini, and the posterior belly of the digastric, as well as the mylohyoid. It originates on the skin and glossal mucosa and from the trigeminal nuclei of the pons, and terminates on the trigeminal nuclei of the pons, and as well as in terms of providing motor supply, it will end on the muscles of mastication, tensor tympani, and tensor veli palatini. So it has 3 different branches, which will go through 3 different cranial foramina. So the ophthalmic division goes through the SOF, have that link with the ophthalmic name. Then it's what we were talking about before about the maxillary and mandibular division. The maxillary division is above, so it will go through foramen rotundum, while the mandibular division is below, going through foramen ovale. So in terms of its sensory information, we can see the split of the sensory distribution of each branch of cranial nerve 5, with the ophthalmic nerve innervating the top third of the face, the kind of ophthalmic area and bridge of the nose, the maxillary nerve innervating the maxillar area, and the submandibular innervating the mandible area and kind of wrapping up and around. In terms of motor innervation, we need to know that cranial nerve 5 is responsible for innervating several muscles, and we need to know what these muscles do. So the tensor veli palatini will elevate the soft palate to prevent food from entering the nasopharynx during swallowing. Then the tensor tympani dampens loud sounds. The mylohyoid is the floor of the mouth, so it's really important for speech and swallowing. And the posterior belly of the digastric depresses the mandible and elevates the hyoid bone. And then we also can see here the masseter, temporalis, and the pterygoid muscles. Perfect. We need to know some of the clinical tests. So in terms of checking its sensory function, we will check sensation to the forehead, cheekbones, and chin area for light touch and pain. You would literally just ask a patient if they can feel as you're tapping these areas, and we're checking each of the branches respectively. Then we can check the corneal reflex. So we place a cotton bud directly onto one eye, and that should elicit a blink reflex. The afferent pathway is V1, and the efferent pathway will be cranial nerve 7. Key thing here is that patients who regularly wear contacts will not really have the corneal reflex because they're so used to putting contacts in. And then in terms of motor function, we can check this by asking a patient to clench their teeth while we palpate the masseter and feel for differences in the bulk of the muscle. Let's move on to the facial nerve. So its functions can be split into sensory, motor, and parasympathetic. Sensory, it's responsible for the taste of the anterior two-thirds of the tongue. And its motor function is that of the muscles of facial expression as well as the stapedius. And it is responsible for the parasympathetic innervation of the lacrimal, submandibular, and sublingual glands. It can present with different pathologies. Bell's palsy is palsy of the facial nerve, resulting in unilateral facial weakness. So, however, if you have bilateral upper motor, so however, if you have, however, you have bilateral innervation of the forehead. So if you have upper motor neuron issues, so if you have an MCA stroke, that would spare the forehead, but if you directly damage the facial nerve, that would not spare the forehead. So you can tell at what level the lesion is. Its anatomical course, it originates in the facial nucleus from the pons, and it terminates on the motor for the muscles of facial expression as well as the spedius, and it for special sensory it will terminate on the facial nucleus in the pons, so just moving back around. And then its cranial foramina, it passes through the stylomastoid foramen. For the We just need to know that it innervates the muscles of facial expression. We don't need to know any of the muscles or what they do, so I would not worry about that. Remember that if you have facial nerve palsy, this will lead to facial weakness, so of the whole face, while if you have a stroke, so that would lead to lower facial weakness. That's because the forehead is spared due to its bilateral innervation that we are talking about. This is the efferent limb of the corneal reflex mediated by the facial nerve. So it's responsible for closing your eyelid when you put that cotton bud in. And it also innervates the stapedius muscle, which reduces the efficiency of auditory conduction during loud sounds. We need to know about its special sensory function and taste. So tastins bind to non-neuronal gustatory cells, which exist within our taste buds, and these are found on the dorsum of the tongue, palate, pharynx, and epiglottis. Gustatory cells project microvilli into the bud's superficial taste pore, and these are covered in several types of receptors. So we have a salt receptor, which has ENaC, which is a sodium channel. We have our sour receptor, which has H plus channels as well as acid inhibited potassium channels. And then we have receptors that can sense bitter, and umami, and sweet taste, which are GPCRs, all being GQ pathways. So, in terms of our special sensory sensation of taste, we need to remember that the anterior two-thirds of the tongue are innervated by the facial nerve, which projects to the NTS of the pons, while the posterior third is innervated by the glossopharyngeal nerve, and that the epiglottis will travel via the vagus nerve. The NTS will send its secondary afferents to the VPM in the thalamus, which will then send information to the gustatory cortex, which is found in the insula. So remember, anterior two-thirds facial nerve, posterior third glossopharyngeal, and the epiglottis is via the vagus nerve. The parasympathetic function of the facial nerve has to do with its innervation of the various glands that we were talking about before. So it provides a stimulatory innervation to the glands in order to increase their secretion. And we need to know that it provides information to the submandibular and sublingual glands. The parotid gland, on the other hand, is innervated by the glossopharyngeal nerve. And for function of saliva, it just provides lubrication and protection of the oral cavity tissue. It has some antimicrobial function, provides an acid buffer, and helps with digestion because it has amylase, so it starts the whole process of digestion earlier, and it also allows for tastins to dissolve and you can sense taste them. In terms of clinical testing, we will check the power of different muscles. So can we ask the patient to perform the following movements against resistance? So we will ask them to move their muscles of facial expression by elevating their eyebrows, closing their eyes, blowing out their cheeks, and smiling. Remember that upper motor neuron lesions will spare the forehead, while lower motor neuron lesions will affect all these muscles. Then moving on to cranial nerve 8, being the vestibulocochlear nerve. This has the functions of providing us with hearing as well as innervating our vestibular system. And the things that can go wrong with it include a vestibular schwannoma and vestibular neuritis. It originates in the cochlea and semicircular canals, terminating on the vestibular and cochlear nuclei, both of them being in the pons. And it passes through the internal auditory meatus. So, just a quick recap of hearing. So when sound passes through the ear, this will lead to movement of the tectorial membrane, leading to the ossicle movement and that moving the actual oval window. This will create longitudinal pressure wave in the scala vestibuli, leading to waves in scala tympani and dissipating this at the round window. The cochlea is a long spiral sac of endolymph in the scala media, which is surrounded on either side by two continuous sacs of perilymph, being the scala vestibuli and scala tympani. Again, this is key information, quite easy to test on. We need to know that the Reisner's membrane is found between scala vestibuli and scala media, while the basilar membrane is between scala media and scala tympani, and this membrane has cochlear inner hair cells lying above. So sound waves will move through the scala media. This will create a shearing effect on the cilia that we can see over here on the tectorial membrane. This will open potassium channels on the ciliary membrane, leading to depolarization of the cell. And we will have calcium-mediated exocytosis of glutamate onto the afferent nerve endings. The basilar membrane gets stiffer the further it moves away from the round window. So high frequency waves prefer moving across a stiff membrane to moving paralymph, and so will tend to cross the endolymph closer. Low frequencies prefer moving paralymph to transferring a stiff basilar membrane and therefore will cross further away. This creates a map of frequency along the basilar membrane. We need to know about the auditory pathways. So auditory nerve fibers project to the nucleus of the cochlea in the pons. So the auditory nerves connects to the cochlear nucleus, which moves to the inferior colliculus, and some will decussate to the lateral lemniscus. And this will move on to the medial geniculate in the thalamus, and finally moving to the primary auditory cortex in the temporal lobe. We also need to know that some of these fibers moving from the cochlear nucleus synapse onto the superior olive before reaching the inferior colliculus. In terms of our vestibular system, we need to know that it's responsible for our sense of balance. So it detects angular and linear acceleration of the head position in order to aid our balance and control our gaze. This is continuous with the cochlea, and we have three semicircular canals, that being horizontal, anterior, and posterior, that sense angular motion, while the utricle and saccule sense linear motion and orientation. Remember that gravity is just essentially linear acceleration. So in terms of our vestibular system, we know that each receptor has a cluster of hair cells that are responsible for transducing head motion. So angular acceleration moves the hair cells faster than the perilymph that surrounds their cilia, and deflection of the cilia in response to a particular direction of movement it results in the same transduction as for inner hair cells. The vestibular nerve projects bilaterally onto the vestibular nuclei of the pons. From here, information is sent to the cerebellum for head and eye posture, to the oculomotor nuclei for the vestibular ocular reflex, and the thalamus for conscious perception of body position, as well as spinal cord for reflex changes in posture. The vestibular ocular reflex, or VOR, is the reflex that enables us to fix our gaze on an object as our head moves around. So, a horizontal acceleration of our head will lead to activation of the vestibular hair cells, activating the vestibular nerve, which, as we said before, connects bilaterally with the vestibular nuclei, and the ocular motor on one side and the abducens on the other. We can see that here. And this will mean that the eyes rotate in the opposite direction to the head. The key pathology that we need to be aware of is nystagmus, which is a gradual drift in gaze in one direction with repeated saccadic corrections. This results from a failure of the vestibular ocular reflex. So, in terms of clinical testing, we need to know about the Weber's and Rinne's test for hearing loss. So in Weber's test, we place a vibrating fork on someone's forehead. If we, in a normal situation with normal hearing, the sound will be heard equally on both sides. However, if we have hearing loss, sound will localize towards the conductive hearing loss and away from sensory neuron hearing loss, that being damage to the cochlear nerve. On the other hand, Rinne's is another test where we place a vibrating fork, but that will be placed on the mastoid until a patient can't hear it. Then it will be placed on the ear. In normal, the patient will hear the sound in the air, so air conduction is better than bone conduction. However, if you have conductive hearing loss, that would mean that you will no longer hear the fork by ear. And then we will also be testing the vestibular nerve, and this is through the head impulse test. So we will ask a patient to fix their gaze directly on you and relax their neck, and then you will suddenly move their head to one side. Normally, a patient can maintain their gaze throughout head movement using the vestibular ocular reflex. However, if you have damage to the vestibular nerve, then you will have a saccade back to you. And this is to compensate for the failure of the reflex. Okay, cranial nerve 5 is the glossopharyngeal nerve. We will split its functions into motor, special sensory, and parasympathetic. It does quite a lot. So in terms of motor, it innervates the stylopharyngeus muscle, which is responsible for swallowing and speech. As we mentioned before, in terms of special sensory, it does the posterior third of the tongue, and for sensory, again, posterior third of the tongue, upper pharynx, tonsils, outer ear, eardrum, eustachian tube, carotid body, and carotid sinus. And again, as we mentioned before, it provides parasympathetic innervation to the parotid gland. In terms of its anatomical course, it starts for its motor function, it starts at the nucleus ambiguus in the medulla, and the parasympathetic branch will start at the inferior salivatory nucleus, also in the medulla. And then in terms of termination, it terminates on all its effectors, and its sensory branch will terminate on the trigeminal nucleus, which is in the NTS in the medulla. Recapping of its cranial foramina, it will pass through the jugular foramen. So as we mentioned before, it innervates the stylopharyngeus muscle. The action is to elevate the pharynx during swallowing. So all the other pharyngeal muscles are innervated by the vagus nerve. So we need to know that it plays a part in the gag reflex. So it is the afferent pathway of the gag reflex, where we will sense an object touch the posterior pharynx, while the efferent pathway is done by cranial nerve 10, which is responsible for soft palate elevation and bilateral contraction of pharyngeal muscles. As we said before, it's also responsible for innervating the carotid body and carotid sinus. as well as the external auditory meatus, eustachian tube, posterior third of the tongue, which also does taste in there, and the oropharynx. And it innervates the parotid gland via the otic ganglion. And we can remember the ganglion because it's quite close to the otic, so kind of the hearing area. You can see that the parotid gland goes quite close to your ear. Cranial nerve 10, vagus nerve. It has a lot of responsibilities, but essentially for its motor, it does the pharyngeal muscles, laryngeal muscles, palatine muscles, and the esophageal striated muscles, being responsible for the top 2/3. It does the taste of the epiglottis and also is responsible for sensory innervation to the auricle and dura mater of the posterior cranial fossa. It provides parasympathetic innervation to the trachea, bronchi, digestive tract, and cardiac muscles. For its clinical tests, we can test soft palate elevation as well as the gag reflex. As we mentioned before, it's part of the efferent pathway. And then its anatomical course. In terms of its motor system, it starts at the nucleus ambiguous as well, and its parasympathetic system starts at the medulla, while the special sensory terminates on the NTS in the medulla, and the sensory terminates on the trigeminal nucleus. And this also passes through the jugular foramen. We can bunch our clinical testing of our glossopharyngeal and vagus nerves together. And we can do this by testing the gag reflex. Remember, cranial nerve 9 is the afferent pathway, cranial nerve 10 is the efferent pathway. So we can also check for soft palate elevation, asking the patient to say ah, checking their voice. Remember that issues with someone's voice would be due to damage to the recurrent laryngeal, which is innervated by cranial nerve 10. And we can also check their swallowing by asking someone to swallow a glass of water. Then cranial nerve 11 is the spinal accessory nerve. Its main function is that of motor, which it innervates the sternocleidomastoid and the trapezius. It originates in the cervical spinal cord and C1 to C6, and it terminates on those muscles, and it enters through the foramen magnum and exits through the jugular foramen. Again, its rootlets arise from C1 to C6, forming the accessory nerve. This will travel through the foramen magnum, an inner wall of the skull, to exit at the jugular foramen. We can test its function clinically by asking our patient to turn their head against resistance to test muscle power, as well as testing shoulder elevation. And this is the only cranial nerve that enters and exits the skull. As we said, for clinical testing, we check power against resistance of the trapezius and sternocleidomastoid cells. So for the traps, we just press down on someone's shoulders, asking them to raise their shoulders. And for sternocleidomastoid, we ask them to turn their head against resistance. Then cranial nerve 12 is the hypoglossal nerve. Its function is that of the motor innervation of the tongue of all muscles except for the palatoglossus. It originates on the hypoglossal nucleus of the medulla and terminates on the, again, muscles of the tongue without the palatoglossus. It exits through the cranial foramen of the hypoglossal foramen, and the clinical test we have for this nerve is looking at tongue deviation and muscle bulk. So we can inspect this by asking the patient to take out their tongue. So if the tongue is deviated, it will generally deviate towards the side of the lesion. And we also see if there is atrophy of their muscle and if they can move their tongue to the left and right. And that is all for cranial nerves. That was quite a quick tour through everything that we need to know. If you have any questions for me, pop them into the chat, but please scan our QR code or use the little link here to give us any feedback that you have on the session today. And yeah, I will. I can't. Let me try and copy it from my other slides. And you can have access to these slides as well. The link is in the chat for everyone to click. I'll hang around for another couple minutes if anyone has questions. But thank you so much for coming today and sticking through a it should be in white text. Let me see if I can change the color, but it is texted on the chat. Can you see the link now? Okay, fantastic. Thank you so much, everyone, for sticking through this, and sorry to keep you on so late. Good luck for your exams, and yeah, I'll just stick around if anyone has questions. Okay, thank you so much for today. Have a lovely evening, guys.
Thanks.